Good evening, ladies and gentlemen. And I am Professor Suresh Sharma, Head of the Population Research Center, Institute of Economic Growth. Today is very important talk on epidemic control in India, refocusing public health services for better outcome by distinguished social scientist Professor Monica Dasgupta on the occasion of 7th Dr. K.E. Vaidyanathan Memorial Lecture. So on behalf of PRC IG Delhi, I would like to express my utmost gratitude to Indian Association of Social Science and Health, IASSH President Professor T.V. Sekhar for giving us the opportunity for collaboration Dr. Vaidyanathan Memorial Lecture with IEG. I would like to welcome President of IASSH, Professor T.V. Sekhar, and our distinguished guests, Professor Ajit Misra, Director, Institute of Economic Growth, Professor Monica Dasgupta, Social Scientist, and Professor Sandhya Rani, General Secretary of IASSH, and all the participants from different parts of India, IASSH EC member, ISP member, and PRC fraternity, IIPS, and Ministry Health and Family Welfare in this memorial lecture. I still remember those times at IIPS when Dr. Vaidyanathan was still in planning phase of building this association. I remember that I would be discussed at length with regarding the theme, the objective, and basically what IASSH should represent. It brings me immense happiness to note that we are all gathered here today for this lecture, Dr. Vaidyanathan legacy continues to life. Moving further, I would like to extend my warm welcome to Professor Ajit Misra, Director IEG. Thank you, sir, for giving your valuable time and look forward your insight message this evening. My heartiest welcome goes to Professor Monica Dasgupta, a distinguished social scientist and a research professor at the University of Maryland. Professor Monica work in demography and public health has found distinguished place today. Her work in the World Bank, the Harvard University continues to stand out and benefit researchers all over the world. It is our most genuine honor to and pleasure to have with us today Professor Monica, as shall I address pathway for the public health strengthening in the light of epidemic control in India. The COVID-19 pandemic has very big clip lead by public health system in India, and I am sure that contemporary relevance of the topic for the lecture will be much appreciated. Once again, I would like to everyone for joining this event, and I am sure all the participants will be benefited by attending this Dr. Vaidyanathan Memorial Lecture. Thank you. And over to President Chair Professor T.V. Sekhar.
Okay. Thank you, Professor Suresh Sharma. And very good afternoon to all of you, Professor Monica Dasgupta, Professor Ajit Misra, office bearers of Indian Association for Social Science and Health, and former presidents of the association, Professor C.P. Pragasham and Professor S. Shivaraju, and dear participants. Let me welcome all of you once again on behalf of Indian Association for Social Science and Health. As you know, it is a professional association of Indian social scientists working on health and development issues. We have more than 1,300 life members cutting across various disciplines. And we are organizing this memorial lecture in collaboration with Institute of Economic Growth, Delhi, I am particularly thankful to Professor Ajit Mishra, the director of IEG, for his readily agreeing to collaborate with us on this important lecture. We used to organize this lecture during our annual conference every year, but due to the difficult times of the pandemic, we are organizing this on a virtual mode. I think I remember this point, some of the important contribution made by Dr. K.E. Vaidyanathan for the demography, to the census surveys, and also the association as such. So I will take a few minutes to recollect some of his contributions. Dr. Vaidyanathan was a very distinguished demographer, and he passed away in 2014 at Bangalore. He was a faculty at the International Institute for Population Sciences, Mumbai, and later he joined at the Institute of Rural Health and Family Planning at Gandhigram as the head of the Department of Population Studies. And there he also served as its acting director for some time. When most of Indian demographers were working on fertility and family planning, Dr. Vaidyanathan concentrated more on the mortality issues, and his book on the mortality decline in India is well known to the researchers. From there, he joined the United Nations system as a UN demographer at the Cairo Demographic Center, which is the regional center for Africa and Middle East. Later, he moved to Syria as the UN advisor to help and establish the Center for Population Studies and Research and to advise the Planning Commission of Syria. This was followed by his posting in Kampala in Uganda to serve as a faculty at the Institute of Statistics and Applied Economics at Makerere University in Kampala. Later, he went on to become the UNESCO Regional Advisor for Population Education in the Arab region. And in 1982, he moved to International Labour Organization, ILO, as a regional expert for household surveys under the National Household Survey Capability Program for the Arab region. So all these assignments, he has contributed greatly to the establishment of population education and conducting census and national household surveys in several countries, particularly in the Arab region. In 1992, he became the chief technical advisor for the Sudan population census, and which was acclaimed as the most successful census ever held in that vast and complex country. In 2001, he moved to head the Living Standards Measurement Survey in Bosnia-Herzegovina, and back to Sudan again in 2007 to conduct the population census there. After his retirement from the UN system, he settled back in Chennai. He took a very active interest in forming and strengthening the Indian Association for Social Science and Health. He was the president of the association from 2007 to 2011, and he was mainly responsible for the expansion of the association to its present form. He was a very outstanding scholar, an excellent teacher, and an expert on health and census matters, and above all, a fine human being. So I'm sure many of assembled here will be remembering Dr. Vaidyanathan, his passion, his commitment, and his hard work for the association, and his very friendly nature and for encouraging the youngsters. So with an endowment from Mrs. Jayalakshmi Vaidyanathan and his family, and considering his significant contributions, IASSH instituted a memorial lecture in his honor in 2014. So this is the 7th lecture in that series. I'm very happy to see that Dr. Vaidyanathan's family members from his daughters and son from Bangalore and Chennai, they have also joined today's lecture program. Most welcome to all of you. So now let me invite Professor Ajit Mishra, who is a well-known economist, eminent researcher, and currently the Director of Institute of Economic Growth, for his introductory remarks. Over to Professor.
Thank you, Professor Sekhar. It's a pleasure and it's a privilege to be here in this occasion of the Vaidyanathan Memorial Lecture and with such a distinguished panel. Now, I thought I would add to the welcome on behalf of the Institute, the Institute of Economic Growth, rather than being welcomed. Okay, so I'm part of the hosting team. So big welcome to all of you, and especially Professor Dasgupta for agreeing to come and deliver the lecture. Can I make a request to all the panelists, those who are not talking, please mute themselves so that, okay. So again, as I said, a special welcome to Professor Dasgupta for sparing her time early in the morning to come and deliver this lecture. So thank you again. Now, I don't want to, I know that the longer I talk, the more you'll have to wait to listen to her. So I'll be very brief and very quick, but I can't help notice that, we can't think of a more suitable time and speaker for exactly, to have a discussion on this, that is epidemic control and public health, the role of public health is. So we have seen the last, several months, how the inadequacies, the frailties and the vulnerabilities of the public health system, especially in India, got exposed. Now, it was probably known, especially to the panelists here, those who work in this area. It was probably known to all of you. But somehow, I guess, in past, India got very lucky with its experience of different pandemics and epidemics. Okay, so in that sense, I would say that it was a lucky escapes for us, the Ebola crisis or all those other these things. But the inadequacies and the frailties were always there. And so now I think so we should not repeat the same experience. That 2 years down the line, we said, okay, it's all over, and we are back to the same old system. And it's not just enough that we, the way economists would look at it is saying how much of GDP are you spending? If it's 1%, 2%, 3%. So I think that's part of it, but that's not, that's necessary, but that's not sufficient to have a well-designed public health system which is going to deliver the necessary health outcomes. I just want to make one remark in the context of this. That is the public goods nature of health. And this is an area where Professor Dasgupta has also worked extensively. So that got, not that it required any kind of reinforcing, but that got reinforced during this pandemic. That health outcomes, health goods are public goods in more than one ways, and that has been felt seriously. If you look at the discussion and the pricing issues about vaccines in Indian context, again the same issue has come up. Okay, that the vaccine should be or should have been treated as the pure public good, and it should have been delivered in that way rather than look for market solutions the way we tried not so successfully. And in fact, I wrote a popular piece saying that it's good that these vaccines don't have 100% efficacy. Okay, the reason being, if it's 100% efficacy, the typical Indian model of privatizing, wherever we see a public's, the absence of, a state or a public body in any space, that would have worked. Why? Because, I could vaccinate myself, then I'm secure. I don't care whether the rest of the world is vaccinated or not. But the fact that, the vaccines are not 100% foolproof makes it again, so I now, as economist, I can't help mention these words. So in my utility function, objective function, now others are going to come in now, because I would like to see, others also get vaccinated. So in that sense, so that has been again reinforced. So that's why, although it should not be taken as a serious remark, but these imperfections kind of drive the public nature very strongly. Now, and the debate or the discussion in the Indian context is more relevant because if you notice, wherever we have seen the state withdrawing or state not, making its presence completely felt, like education, like health, we have seen, the private sector or the private these things has come in a big way. But there are certain areas, and the pandemic control has brought, both in terms of prevention as well as in management, that we cannot have a market solution to all these problems. Okay, and so the need or the justification for a public health system is probably more than ever. And so in this context, so I really look forward to your lecture, Professor Dasgupta, about how we can use the refocus. I like the term, the public health systems to achieve better outcomes in this context. So without anything, I leave over to the chair to proceed, and look forward to hearing Professor Dasgupta.
Thank you, Professor Misra, for highlighting the importance of health system and the relevance of the topic what we are discussing today. Now, it is my great pleasure and pleasant duty to introduce our guest speaker. I think Monica Dasgupta needs no introduction to this Indian social scientist and demographers. She is well known for her very rigorous and innovative research and publications on many pressing issues of India's population and society. She is trained both in anthropology and demography at the London School of Economics and the Institute of Development Studies at the University of Sussex. Monica had a very distinguished academic career. She is currently the research professor at the University of Maryland in USA. Before that, she worked with the World Bank's Development Research Group for a decade, and she was also at the Harvard University Center for Population Studies and also at the National Council for Applied Economic Research, NCR, in New Delhi. So Monica has published extensively on issues of population, poverty, gender, health systems, and development. I remember one of my favorite papers is her 1987 paper published in Population Development Review. It is on selective discrimination against female children in Punjab. And I'm sure many of you must have referred that paper. This is one of the earliest and most widely quoted study on gender bias in rural India. Later, Monica worked on issues related to sex ratio and son preference, not only in India, but also in China, South Korea, and many other countries. And she has significantly contributed our understanding of the manifestation of gender bias and how it has implications on fertility decline, particularly in developing countries. And it is through her research, we also observed that child deaths in many of these developing countries are clustered in few households, as well as how the family and kinship systems are shaping the gender differentials in these societies. So another important area of Monica's research in recent decade is on public health system, structuring the public health component and its performance. I had an opportunity to collaborate with her on a World Bank sponsored study, which she was leading, on restructuring public health systems in Karnataka that was carried out in 2005-06. So she essentially focuses on the successful models of low-cost preventive public health systems. And that is the best way to prevent and protect, basically to protect people from epidemics and diseases. So for today's talk, Monica has chosen a very relevant issue, as mentioned by Professor Ajit Mishra, that is on epidemic control in India, refocusing public health services for better health outcomes. I'm sure she will be talking today about the strengths and weaknesses of India's public health system, which is a very crucial issue for all of us, particularly in the context of a devastating pandemic that we are experiencing in our country now. So, ladies and gentlemen, I do not want to stand between you and Monica now. So it is my privilege to invite one of the finest demographers and health researchers of our times, Professor Monica Dasgupta to deliver the 7th Dr. Vaidyanathan Memorial Lecture. So we will have some time up for discussion after the lecture. So please send your questions in the question answer box, and Monica will be very happy to respond to those questions after the talks. So over to Monica now. Thank you.
Thank you, Professor Shekhar. Thank you for inviting me. It is a sad occasion because Professor Vaidyanathan was such an inspiring professional and also such an inspiring human being. It's a great loss to our discipline to have him pass away really quite young. I'm also very grateful to Professor Mishra, since he's an economist, that he's interested in issues of public goods and health. Not very many economists are. And unfortunately, it's economists who have the ear of policymakers. So it's wonderful to hear somebody taking an interest in the public goods aspect of health services. And I hope very much that you'll be able to influence more people to think along the lines that you discussed just before this. So I'm going to share my screen now. And start by apologizing for, this is not a routine research presentation where I have a paper and I put it together and I present it to you. Because of COVID, I tried to put together some thoughts on what the nature of the problem is in India and also elsewhere, primarily in India. So it's really throwing out a bunch of ideas. And I added some slides which there won't be time to discuss here, but for anybody who's interested in picking up on these issues, you might find some of the extra slides and web links of interest. So firstly, what is public health? What does a public health system do? What do public health systems need? I'll talk about the kinds of structures they need at an international level, national, state, and local. What kind of staffing do they need? Not just medical staff, but other kinds of technical staff and grassroots workers. What are some of the essential features for these systems to be effective? They absolutely need autonomy and low political interference. And they also need to focus on the weak links in the chain, not the strong links, because it's the weak links that bring the whole chain down. And then I'll conclude with a quick summary of the key gaps in India's public health system. So what is public health? There's a lot of confusion about this all over the world, starting with the World Bank, which often thinks that public health is services that are publicly funded. Well, typically they're thinking about hospitals and clinics. Public health, to quote Canada's Chief Public Health Officer, public health is about preventing disease rather than treating the illnesses of individuals. And then to quote Winslow, who was a pioneer of the US public health services back in 1920. So you do this largely through sanitation of the environment, control of infections, education and personal hygiene, and organizing medical services for the early diagnosis and preventive treatment of disease. There's a heavy focus, as you will see in the Canadian and the US quotes, there's a heavy focus on communicable disease, which is important because one case infects others. If I have diabetes, it's not going to affect you, but if I have typhoid, it could well affect you. So the whole question of public goods is how you put a lid on diseases that can spread from one person to another. Public health is not to be confused with publicly funded medical services, and sometimes it's even confused with private insurance for medical care. What's the purpose of public health? And here I'm quoting from the US Centers for Disease Control, 2020. The purpose is to prevent epidemics and the spread of the disease, to protect against environmental hazards, to prevent injuries, to promote healthy behaviors, to respond to disasters and assist communities in recovery, and to assure the quality and accessibility of services. So there are three broad types of health services. Sorry. There's the clinical therapeutic services, hospitals, clinics, that focus on treating the individual. And this is mostly private goods. So an individual who's treated gets the benefit of that treatment. In the case of communicable disease, if you treat somebody who has TB, you're also creating a public good because they're not going to give other people TB. But for the most part, it's private goods. Then you have clinical preventive services such as immunization, antenatal care, which are partly private, partly public in nature. And then you have a focus on population-wide services to reduce exposure to disease. And these are pure public goods and cannot be left up to the market to provide. The market has no adequate incentives to provide these. It has to be provided by the state. And if the state fails to provide these adequately, basically the state is leaving inadequate development infrastructure. You have a sick population, it's bad for the labor supply, it's bad for individuals, and it's bad for economic growth. So these public goods are really very important. If you think about, for example, where I live, Washington, DC used to be a malarial swamp. By investing in underground drainage, they created a place which has no malaria and was able to boom into a large city with all manner of sources of growth. That's the importance of the state investing in public goods. It's just one example of that. Unfortunately, medical services are often prioritized over public health services. And this is often to do with the fact that public health services have intangible results. Success in public health is defined by an absence of adverse events. You rarely get a major newspaper in the developed world saying, banner headlines, no typhoid last year, because that's taken for granted. But an advance in medical treatment is big news. And it's difficult to do much to even get the necessary budgets, because if nothing happens, people think, well, why did we put the budget in? The WHO was criticized for, quote, exaggerating the swine flu threat because the outbreak was limited. Well, the outbreak may have been limited because they took the threat seriously. And there's a lot of incentive to divert budgets to medical services. Politicians can win easy approval by opening a hospital, by starting a health insurance program. And this is reinforced by important private sector lobbies that have an incentive to open up these services, and also, unfortunately, by donor agencies. Again, middle-class citizens often put pressure on the government to divert budgets to medical services because they don't feel threatened by communicable diseases personally, and they would like to have their local hospital to have the latest CAT scan equipment. Management is crucial for public health. This is basically a matter of management. This is a quote from the architect of Japan's public health system around 1871. He spent several months in Berlin trying to learn about the German public health system. And he said, when I arrived in Berlin, I heard the words sanitary and health everywhere, but I didn't really understand those words. I eventually came to understand that these words referred to an entire administrative system that was organized to protect the public's health and to improve the nation's welfare. So what does a public health system do? Some key services are to monitor actual and potential threats. And these threats can come from diverse sources, from different kinds of animals, from different kinds of insects, from climate change. There can be a diversity of sources of health threats that are here and now, and also potentially down the line. A public health system needs to monitor both actual and potential threats. As potential threats become more actualized, they need to mobilize a public response to these threats, inform people, use whatever public health laws are available to them. And they need to provide services to respond to these threats and to avert them. They need to address the sources of threats, whether it's vector control, sanitation. They need to reduce the spread through contact tracing, vaccination, treatment, etc. And I'm not going to go into this in detail. I've just put this with the web link for anybody who wants to. This is the CDC's breakdown of what you need to do in a public health system, the various activities. So what do public health systems need? Certain kinds of institutional structures they need, and certain kinds of staffing. So first, the institutional structures. At the national level in India, the NCDC, National Communicable Diseases Center, is set up to be the national institution with the technical capacity to link with international institutions, whether the WHO, the US CDC, others. There's a bunch of international institutions which share information with each other and with the apex national institution. So the NCDC has the technical capacity to link with these institutions. And in principle, they have the capacity to link with state public health authorities down to grassroots. At the state level in India, you should have a public health directorate, which plans and coordinates public health services down to the local level. Unfortunately, most states don't have this. Tamil Nadu does have it. It has a directorate of public health, which is a good model for other states, and I'll be talking about that later. No separate public health services in most Indian states. Why is that? Well, before independence, they used to have these. The public health services was called the sanitary department, and the medical services was called the Indian Medical Service. Doctors in the sanitary department had better pay and faster promotion than those in the Indian Medical Service, so it was a privileged service. And it was privileged for a good reason, to provide these public goods. In the 1950s, the central government asked the states to merge these services. And many states, if not most states, did this, which led to the atrophying of public health services because resources were diverted to medical services, and because of the pressure to provide tangible goods that politicians can benefit from. Tamil Nadu retained the separation of public health and medical services, which gives it a huge organizational advantage relative to other states. This is not to say every outcome in Tamil Nadu is better than other states. No, it's to say that when it wants to do something, it has a huge organizational advantage. Tamil Nadu has a strong public health administration, which is quite simple and professionally run. It has its own dedicated staff with a tight management structure. They can hire, train, and manage their own staff, which, for example, the NCDC in Delhi cannot. They have a clear allocation of responsibilities from the state level to the grassroots level. They have their own dedicated budget. They can hire a full range of the necessary staff, whether that's epidemiologists, entomologists, laborers on the ground who catch rats and check them for fleas, all kinds of things. They know what the full range is because they're the dedicated professionals in public health, and they have the budget to hire all the full range of support staff. And they have the budget to finance activities to avert potential threats and manage disasters. They're not accountable for saying, oh, well, we didn't have a plague epidemic last year. Why don't you shut down the plague control center and save some money? They can avoid that kind of pressure. They have a Public Health Act, which gives them an umbrella mandate for public health action. And the Directorate of Public Health has authority over public health activities across the whole state, including the Chennai Municipal Council, and the head of the DPH, the Director of Public Health, is the technical advisor to the Department of Health. So quite an esteemed position, taken quite seriously. They work closely with the state and district administration. Every year they have an annual meeting with, which is called by the IASSH office, the district collector, and it's attended by people from all the different major departments in the district. And they discuss what possible threats there are. If there's a flood, what do we do? If there's X, what do we do? So all the departments understand what actions they need to take if there's an emergency. This brings to the attention of the entire administration in the state what is public health and what needs to be done. It makes it much less difficult for politicians to mess with this, because it's not just the public health people who know what needs to be done. The entire state administration has at least a tolerable understanding of what needs to be done. So it's much harder to override the way, for example, Boris Johnson did, or President Trump did here, to say, oh, rubbish, this is nothing. We don't need to worry about COVID. And of course, you got huge outbreaks. The Tamil Nadu model is easily replicable in other Indian states. It uses exactly the same ingredients, the same facilities, the same infrastructure of state hospitals, district hospitals, primary health centers and sub-centers, exactly the same categories of staff, doctors, nurses, technicians, male and female outreach workers. They just organize these ingredients differently. They separate their medical officers into two tracks. 99% of their medical officers are in the medical track. They work in the hospitals and clinics. 1% are dedicated to the public health track, and they're given a short training in administration to manage public health and primary health centers. And I highlight the matter of short training because when the Planning Commission some years ago was thinking about these issues, they came up with the bright idea of, oh, if it's a matter of management, we'll put MPHs in charge of public health services. And no, you do not need MPHs in charge of public health services. You need medical doctors with a very short training in how to manage public health services. And this enhances the efficiency of both sets of services. And it's done within a budget similar to the Indian average. So you look at Tamil Nadu's per capita health expenditures. This is India as a whole. This is Tamil Nadu for government health expenditure per capita. Slightly less, well, about the same as India as a whole. In Tamil Nadu, slightly more in Kerala. If you look at total health expenditure per capita, Tamil Nadu is slightly above that of all India because they spend slightly more on private care, and Kerala spends much more on private care. So Tamil Nadu and the average Indian state are in the same ballpark in terms of expenditures, which brings me back to Professor Sharma's point that you don't actually have to spend more, you have to spend better. The system has many strengths, Tamil Nadu's system. For example, they can maintain monitoring centers for potential outbreaks. They continue to maintain their plague center, although they haven't had plague for decades. There's two other areas of India where you can have outbreaks of wild plague. One is in the border between Maharashtra and Gujarat, and one is in Himachal Pradesh. In both cases, they shut down these centers. And in both cases, in recent history, there were outbreaks of plague. And then I talked about the annual review to prepare for disaster management that district collectors organize. One example of how this annual review helps is when they had the tsunami. They had a very smooth and effective response to the tsunami using their normal resources. What do public health systems need? The kinds of staffing that they need. They need technical workers with a very wide range of expertise because there's a very wide range of sources of threat, potential threat to human health. And they need good grassroots workers. In India, we have an excellent, well-trained cadre of ANMs, the female health workers. The male health workers have been neglected to a very large extent, and their training has been badly neglected. So what are the duties of grassroots workers? Here's something from the WHO Europe division. The basic duties of these grassroots workers is to assure water safety, food safety, waste management, housing conditions, vector control, investigate and manage disease threats, occupational health, air quality, and they also work at borders and ports. This is a very important range of activities. It goes way beyond what male health workers in India are largely left untrained and are used to assist other categories of staff in various kinds of activity. It's like two different worlds. What a grassroots health officer needs to be able to do, needs to have the training and the authority to do, and what our male health workers have the training and authority to do. Basically, very little training and almost no authority. These are the duties of public health inspectors in Sri Lanka. They're given 18 months rigorous training in the classroom and in the field. And they're very similar to the ones you just saw for Europe. Investigate and manage diseases. So for example, they routinely do contact tracing and follow up with treatment defaulters, TB, and so on. And they played a key role in COVID management in Sri Lanka. And water safety, food safety, waste management, housing inspections, all these things that you just saw in the European context, they do. And anybody who's interested in this would benefit from reading the Sri Lanka Manual for Public Health Inspectors. This is the web link to the manual. One thing they do, for example, is they supervise latrine construction. They make sure that they're properly constructed. They're given some training by the engineers in charge that in this area, this is what you should pay attention to, and they supervise that. It's not just farmed out to, you know, panchayats and so on to just do somehow. It's done properly. Very important point. Another thing that they do is they check the sanitation of hospitals. They supervise the conditions of how medical waste is managed, how the food is prepared, and so on. They supervise all this, and they submit reports to the head of the institution on how they need to improve their sanitation. This is just a very important function. And if you don't have that important function being properly fulfilled, you get situations as you get in the All India Institute of Medical Sciences in Delhi. You get, you know, contaminated food being sold by vendors in the compound. You get outbreaks of dengue because nobody's paying attention to the coolers. These are just very important functions. I really wish that the Indian government and or specific states in India were to just hop across the short distance to Sri Lanka, visit their public health training institution in Kalutara, see for themselves how their training is done, and get hold of their training manual. It's an example for the world, quite frankly. They're trained very comprehensively on a wide range of topics, as I just told you. They're trained above all to work confidently, to organize their own work plan according to the changing needs of the population that they're in charge of, following, of course, clear overall guidelines. They have a detailed manual to refer to. And very, very importantly, they're treated with respect. They're not treated as sort of, you know, people to kick around. They're treated with real respect. And when doctors are undergoing training in community medicine, the public health inspectors help give them field training in their community medicine courses. Just one indication of the respect with which they're treated. It's very well worth emulating. I've put this picture up because I'd like you to just look at the faces of these public health inspectors. They work with a lot of authority, but they're not, there's a lot of emphasis on not abusing authority. People can report them, they know that if they try to abuse authority, but above all, they're trained to work with people and not to wield a lathi. Now, what are some of the essential features for a public health system to be effective? They need autonomy, low political interference, and focus on weak links in the chain. Autonomy and political interference at a national level is quite staggering. The NCDC and its precursor, the NICD, National Institute of Communicable Diseases, is just plain micromanaged by the Ministry of Health and by the people in the Ministry of Health who are basically administrators, IAS officers, who may be well-meaning, but their last posting may have been in petroleum. So they don't necessarily understand the issues. They're micromanaged in their hiring, in their firing, and in what they're allowed to do. In this recent COVID epidemic, they've been sidelined to a very large extent. Advice taken more from the ICMR than from the NCDC, whose job it is to actually manage this kind of thing. You see exactly the same pattern with COVID in the US. Huge political interference with the functioning of the Centers for Disease Control here, which was basically paralyzed with the political interference. And attempts increasingly by politicians to restrict the powers of local health departments to respond to COVID. The politicians want themselves to have those powers, but of course they don't have the training. And this is very, very bad for outcomes. As you saw, until recently with the successful vaccination program in the US, it was just mayhem with the spread of COVID. And globally, countries are typically reluctant to share information on their weaknesses with other countries. That is improving with COVID. Then there's autonomy and political interference at state and local level. A prime example of this is the devolution of service delivery to elected local bodies, the PRI amendments. As we noted earlier, politicians are demotivated to worry about public health because they can't claim credit for a lack of disease at the next election. They can't say, oh, well, you see, because we were here, you didn't have typhoid. Tamil Nadu retained much of the autonomy of the State Directorate of Public Health, and they have overriding powers to protect public health across the state. It's not, the powers of elected local bodies are constrained in that context. The next thing, the essential feature, is to focus on weak links in the chain. This is absolutely the first, the middle, and the last principle of public health service provision, that outcomes are driven by the weakest links in the chain. You ignore the weakest links, you get a spillover of contagion. Unfortunately, in India, civic services are very unequally distributed. Water, drainage, sewerage, garbage collection, etc. And the sanitary conditions for slum dwellers actually worsened between 2008 and 2012. The proportion of slum dwellers without toilets doubled, the proportion without drainage doubled, and the proportion without garbage disposal didn't double, but it increased sharply. The neglect of slums affects everyone. It means that diseases remain endemic. They are not eradicated. And the slums remain a source of infection for everyone. Just one example is, as an outcome, is child stunting. It's easy to measure because the NFHS collects those data. Repeated infections from contaminated environments expose children to stunting because they're unable to eat as much. They're unable, what food they do eat, they're unable to digest it and process it. And at the same time, their body requires more energy to fight the disease. So children get stunted. And stunting is associated with lower cognitive ability, lower earnings, and longevity. Now, elites don't really recognize this threat because they have access to medical services, so their children don't die, or even they rarely fall seriously ill. but they are subject to subclinical infections, and they do have high levels of child stunting, shockingly high levels of child stunting. The wealthiest quintile of households in India, if you compare, this is child stunting rates for India compared with Haiti, Bolivia, Honduras, and Sri Lanka. These four countries have roughly the same GDP per capita. Sri Lanka is wealthier, but not hugely. What you find is that overall, for the poorest, Sri Lanka's poorest have much lower stunting than India's poorest. India is an outlier in stunting amongst the poorest, but it's an enormous outlier in stunting amongst the richest. And that's something that really should make one pause and think. Tamil Nadu tries to pay more attention to the vulnerable sections. I said tries. I mean, they do their best, and a lot of things are not in their hands. But doing their best seems to work. The slum, non-slum gap in Chennai is quite small. Child stunting 28% in the slums, 25% in non-slums. In Delhi, child stunting is 51% in slums and 38% in non-slums, which means that children in Chennai slums are much better off than people in Delhi who do not live in slums. It's one very rough way of illustrating the importance of focusing on the weakest links in the chain. Protecting elites was in fact a key motivation for Western governments to improve sanitary conditions in slums. Here's a quote from somebody who did a history of public health in a number of developed countries. The knowledge that the diseases of the workers who sewed clothes in their filthy tenement homes or who processed food, the knowledge that their diseases could be spread to decent, clean, and respectable citizens served as a powerful incentive to the reform of public health. And so they invested in upgrading slum conditions and housing, water drainage, and sewer systems in slum areas. And it pays off, as you saw. It pays off not just for poor people, but for wealthy people as well. Public health measures were very important for reducing mortality in the developed world. This is the US. You see how mortality dropped before the mass availability of antibiotics became available. And this huge drop was largely due to public health and sanitation measures. And just in passing, what this shows you is daily calories per capita around 1940. Daily caloric intake in India was not very different from that of Korea, Taiwan, and Japan. That's basically Japan and its two immediate neighbors who were colonies of Japan at that time. And Japan had put in their health system in both Korea and Taiwan. So their caloric intake was about the same, but their life expectancy was way higher than that of India. And the difference can be attributed largely to the nature of their public health measures, the lack of contamination. So to conclude, here are some of the key shortfalls in India's public health systems. The gaps: inadequate structures at national level, state and local level, inadequate staffing. I actually went to a state and they asked me, who would you like to talk to? This was in the health department. And I said, I'd like to talk to the entomologists. And they said, entomologists, very slowly, and wrote it down painfully. the state health department doesn't know what an entomologist is. And I have to tell you, the director of public health, retired director from Tamil Nadu, was helping in other states. And he said, "Madam, I was in Bihar and they have one entomologist in the whole state. And madam, he by training is a statistician." I mean, his eyes were almost falling out of his head. Inadequate staffing in non-medical technical staff and in trained grassroots workers. They suffer from low autonomy and from a lack of focus on weak links in the chain. As a result, many simple diseases remain endemic, generating a high cost for everyone, for the nation, and for every individual in the nation. And new diseases like COVID are able to run rampant. And here's my favorite quote from someone called Laurie Garrett. "Focusing on clinical services while neglecting services that reduce exposure to disease is like mopping up the floor continuously while leaving the tap running." Thank you.
Thank you, Monica, for that excellent talk, highlighting the need for strengthening India's public health system, and also highlighting the strength of the Tamil Nadu model. And broadly, I think you have also covered what are the shortfalls and gaps in our public health system, in their training, in their infrastructure, in their manpower. I think we will have some time for a question answer session. So if anyone would like to give some comments or have any questions to Monica, please feel free to do so.
How do you,
Yes, Professor C.P. Pragasham.
one of the fundamental questions I want to ask that, how do you distinguish between public health and community health? And how the manpower can distinguish between these two?
I wouldn't distinguish between those two. I think they're very much the same thing. I mean, the objective of public health is to assure community health. Some of the actions in a public health system may not pertain at the community level, may pertain at higher levels. But nevertheless, the objective is to assure community health.
In that case, how this public health, you said that public health is only for curative purposes, preventive diseases. Public health is for preventive diseases. Then in that case, is there any difference between the treatment medicine and public health? Public health, you said that it is a preventive disease, preventing for the disease.
Mm-hmm.
In that case, medicine is for treating the community people so that the disease will get treated and it will be cured. Is there any interlink between these two, and then how it goes with that?
Absolutely, there's an interlinkage, but public health goes much wider than the treatment. So in the case, for example, of
Malaria, something is there.
Malaria, okay. In the case of malaria, you need to pay attention to what's the density of mosquitoes, what kind of mosquitoes, not all mosquitoes can transmit malaria. You need to actually measure density, you need to measure.
But will it not cross epidemiology?
I'm sorry?
Will it not touch epidemiological approach?
I'm sorry, I don't understand the question.
These preventive diseases will also, you say that the density and all these things, but epidemiologists will come into that picture
Absolutely, yes.
identify what would be the situation of the community, and then they will try to make is it a pandemic, is it a communicable disease or something, and suggest some preventive procedures.
That's right. Yeah, that's right.
It-
And
that
not
means
just suggest them, but actually carry them out. So just to give you an example, the US is quite an interesting example for two reasons. One is it has a broadly similar federal structure to India. And the other is it has all these tropical regions which have had similar kinds of disease. So malaria was huge across the southern states. And to this day, they, having got rid of malaria effectively for all practical purposes, many, many decades ago, to this day, they monitor water levels in their dams to make sure that mosquitoes can't breed. So you never stop, even if it's been 70 years since your last case, you still continue to make sure that they can't come back and breed and cause a problem again. So that's, in that sense, it perhaps answers your first question, that it's not just a matter of treatment. Treatment is very important, but there's many, many steps to prevention, which has nothing to do with medical care. I hope I
Okay.
managed.
Thank you very
Yes,
much.
thank
Thank
you.
you very much.
Thank you.
Thank you.
There is one question in the question answer chat box. It is on the, is there a policy to maintain hygiene and sanitation?
Is there a policy where?
Yeah.
Policy where? Does it say? Or
Yeah.
can there be a policy within 1 mile peripheral?
I think it is linking with the corporate social responsibility and hygiene and sanitation management. I think the question is related to that.
Right. It would certainly be very nice if that were to happen. But it's a sort of icing on the cake, because the basic infrastructure for sanitation and hygiene has to be publicly provided. But social responsibility can do many things. It can assure sanitation within 1 mile radius. It can also assure that they make sure that their own air conditioners and coolers are not creating a problem. There's many things that they can do themselves. And also individuals. I mean, there are countries in this world where people organize school children to go out and, pick up unnecessary trash lying around. That can only be done in a situation where there's very little of that trash lying around. But it does inculcate. You see some photographs in Sri Lanka and Tamil Nadu of communities mobilizing to clean up their neighborhoods. It probably helps not just the immediate cleaning, but also making people more aware of the need to be more careful with how they dispose of garbage. But as I say, this is all icing on the cake. The real infrastructure has to be provided by the state.
Yes, I think Professor K.N.M. Raju want to say something.
To the best of my knowledge, public health was always associated with local bodies, local governments, like municipalities and all. Am I right?
I'm sorry, your voice was unclear. Did anybody catch that?
Public health was associated with the local bodies, local governments, like municipalities and all that. sick tools and all that. Am I right?
I think Professor Raju is asking how far the local self-governments and local bodies are important in ensuring the public health issues.
They're very important, but without oversight, it's easy for them to neglect these issues. So, for example, in Sri Lanka, one of the jobs of the public health inspector is to supervise the local body staff who go out to sweep. At least in the equivalent of districts and small towns. In the bigger towns, the local bodies have more autonomy. But in the districts and the smaller towns, the public health inspector's job is to make sure that they have the equipment, that they go out, they do their job. That's an important one. And it's important to have that accountability because you know, in Delhi, for example, it's left up to the local bodies. If they don't perform, if the sweepers are not performing, then if people complain in the neighborhoods, then they're told, then you monitor them. Well, how are people in neighborhoods going to monitor staff that they have absolutely no authority over? You know, if the staff don't have the equipment, they're not in a position to give them the equipment, they're not in a position to do anything. So this whole thing of saying that, you know, localities are responsible for their own outcomes is really ducking the question of public sector responsibility for making sure that these activities get taken care of. Does that answer the question?
Yes. Professor Tim Dyson is raising his hand.
Thank you. Well, it's a very interesting talk. It's something I know very little about. I've got one observation and perhaps two questions. The first observation is that Tamil Nadu and Sri Lanka are both in the south, if you'd like to put it that way. Yeah. Well, it's obviously a fact. The second is a small point, and how have these two populations done vis-a-vis COVID? And it's too early to say anything definitive on one would imagine, but nevertheless, there maybe you have an idea, maybe other people have an idea as to whether they've reacted somewhat better, which obviously will be consistent with your thesis. But my main question really is, right, it's everything you said seems 100%. How does one therefore reinvigorate, re-establish the public, how does one begin to re-establish the public health service dimension of healthcare in the other states? That's really my main question.
I don't know how to answer your question, Tim, because if they wanted to, they could do it very easily. It's just a question of wanting to, because as I showed, it doesn't cost any more in Tamil Nadu than in the average Indian state. And Tamil Nadu is a wealthy state compared to the average Indian state. It also, you know, they have clear models right there at hand. Any state that's interested in setting up a proper public health system needs only to go take a look at Tamil Nadu. Don't sit around imagining it and making up, you know, what they think needs to be done. Just see something on the ground that works well. Tamil Nadu's superstructure of public health is very, very good. Where they need to learn from Sri Lanka is where Tamil Nadu also needs to improve their act, is in the training of male health workers, the training and the authority of male health workers. The way the Indian government has used male health workers basically to assist in this and that and the other, ever since smallpox eradication, they were not trained to do anything specific on their own. And Tamil Nadu is trying to improve that situation. In Sri Lanka, the male health workers are really outstanding. I mean, they're outstanding in a world-class sense. And again, it's not expensive. And all you need to do is take a short flight to Kalutara to look at their training manuals and to observe how the training is done and how these people actually work. I've followed their public health inspectors around when they do food inspections, for example. And I've observed from outside the expressions of the people that they're inspecting, you know, in a small shop or in a small tea shop. Their expressions are not of fear or anything. Their expression is really, oh my goodness, the headmaster's here. We're going to get a talking to. So they're expecting to be told stuff in a somewhat authoritative way, but they're not expecting to be asked for a bribe or for free food or anything. They're expecting to be treated professionally and just be advised on how they can improve their act. So it's all there, and it's right there. You could take the same flight, stop in Chennai and stop in Colombo. I mean, it's the problem seems to be that, you know, there's a lack of adequate interest in doing it. And the second problem is that even when people get interested, they think they can make it up from you know, basic principles. One can't. I mean, just to give you an example, a Gujarat state tried. They thought we should have a public health act, and they devised one which included regulation of medical staff. Now, Public Health Act should not include regulation of medical staff, because that's a completely different kettle of fish. It means that you don't understand what a Public Health Act is. You're trying to make it up from scratch and you're making it up wrong. And secondly, the problem with that approach is that medical people are very organized, and they started marching on the streets in protest and killed that act. You know, don't start from first principles. If you have something right there in the country or right next to the country that you can build on, use it. It doesn't cost much. And as I said, the ingredients of the Tamil Nadu system are identical to the ingredients of the system in any state of the health department. You just separate the budget, separate the staff, give people in their own places the autonomy to manage their own systems. Don't mush it all up and make people compete. You know, you're going to have a plague center, you're going to have another CAT scan machine. If there's that competition, it's three guesses. Of course, you're going to have a CAT scan machine. You won't have a plague center. So yeah, in terms of how they responded to COVID, or for that matter, anything else, Sri Lanka had pretty good response, but it's easy because it's an island. So you can protect your borders to a considerable extent. Tamil Nadu is by no means an island. It's a fairly prosperous state. There's huge amounts of migration in and out of Tamil Nadu, labor migration. So it's very far from being an island. So they have a different set of issues. But what you can see, for something like COVID or polio, it's not an island. But when you get, say, a flood, a specific, you know, the Chennai flood or the tsunami, which is something that you're not importing potential contagion from outside, they move very swiftly and very effectively. Or again, as I said, take control and so on.
Thank you.
Okay. I think the one last question, I think Professor Patricia Oberoi, it is there in the chat box. Monica can respond to that. From Patricia Oberoi.
Oh, sorry, in the chat.
I think it is more or less like the question what Dr. Tim Dyson raised now. Do you find the management of present COVID pandemic actually bears a relative optimism?
No, I think India is another example, prime example, along with the US and the UK, of politicians overriding public health personnel in terms of the response. You know, they're going to take last decision, and it's going to be driven by politics and not by public health considerations. I'm not saying that only public health considerations should be taken into account. Obviously, there's many considerations, but you can't just totally override it as Trump did and is still trying to do. And Boris Johnson did at the beginning. And most recently in India, holding that Kumbh Mela and all those election rallies, it's taken a big toll. Was very likely a very bad mistake for India and a very bad mistake for the world.
Okay, I think now it is almost 6 p.m. I think we had a very wonderful presentation and a good discussion on this very important issue. Thank you, Monica, for taking your time and talking to us and highlighting some of the challenges before the public health system in India. So let me thank you very much. Now, to propose a formal vote of thanks, I invite Professor P.M. Sandhya Rani from the Tata Institute of Social Sciences, who is also the General Secretary of the IASSH. Over to Professor Sandhya Rani.
Before that, can we have a photo session, please? We can open your videos.
No, let us have the vote of thanks, then we will have to.
Thank you,
please,
sir.
please. Professor Sandhya Rani.
She's muted.
Please, you are muted. Yes.
Thank you. Good evening. I think good morning for Professor Monica Dasgupta. There it may be morning. So in India it is evening. So at the outset, on behalf of IASSH and myself, we are very much thankful to Professor Monica Dasgupta for taking this session, giving the memorial lecture of Professor K.E. Vaidyanathan. Madam, I just want to share something related to my work, because when I was writing a report referring your name, because I referred your book, Health, Poverty and Development, that edited volume book, I was quoting your name as Monica Das Gupta separately, but my former dean, who is also from West Bengal, he is told, Sandhya, don't separate Das and Gupta, it should be Das Gupta only. Then I told, sir, no, I referred the book, there it was written Das and Gupta separately. So that was my experience with your name, madam. Just I want to share here. And And just I want to share 1 minute. What about the public health and epidemic? It is a latest experiment in Andhra Pradesh state. They have started last 2 years decentralization model, like starting village or ward secretariats and recruiting volunteers for every 50 households. This volunteers work is for monitoring complete and holistic way of the 50 household allotted to them. Everything including PDS and vaccination, on toilet constructions, or all other welfare schemes, whether that particular household is receiving from the government or not. So this is somehow, that means a very robust way of monitoring the things through volunteers. I think it may be, it is just started for 2 years only. It is still we have to see, but so far it has given little bit, because covering the vaccination, include the COVID test, has been given successful results, madam. Just I'm sharing with you. So then we are thankful to Professor Ajit Mishra, Director, Institute of Economic Growth, sir, for giving the introductory talk related to this program. We are thankful to you, sir. We are thankful to Professor Suresh Sharma of Institute of Economic Growth for giving welcome talk for today's program. And we are also thankful to all our former presidents of IASSH, Professor PKB Nair, Professor CP Prakasam, Professor S. Sivaraju, for all their advice and suggestions for all our programs. We are thankful to our Vice President and Dr. U.V. Somaya Jalu for his contribution, disseminating all the activities through social media. We are thankful to all our executive committee members and board of trustees of IASSH. We are thankful to all our other workers, the staff members like Professor Gandhar Pednekar, Rashmi Sharma, Dr. Murugesan, and Mr. Anjali Mishra for the logistic support. We are thankful to Mrs. Jayalakshmi and the family members of Professor Vaidyanathan for their cooperation, interest for giving this lecture, memorial lecture, contribution, financial and all. We are thankful to them. And, we are thankful to all our participants of today's program and giving their advice or participating in the question answer sections, everything. And then we are also thankful to all our participants. And Professor T.V. Shekhar, President of IASSH, who has initiated this memorial lecture and very actively doing all our work with our members of the EC members in IASSH. Thank you, Shekhar, for taking this interesting and very valuable lecture by Professor Monica Dasgupta. I am very much thankful to you, ma'am, because we refer all your work. Especially I work in this area of health and all. I am from Center for Population Health and Development, School of Development Studies, Staff and Social Sciences. That's why I extensively refer all this work. Thank you so much for all the participants of this program. Thank you.
So thank you all, and so nice of meeting all of you, and thank you for participating, and special thanks to Professor Monica Dasgupta once again. Thank you. So we are concluding this program now. Thank you.